All right, good night. Tonight, we'll be presenting on the management of GBM. All right, we'll start with the redefinition of the term glioblastoma. So the term glioblastoma multiforme is now obsolete, but glioblastoma, or the abbreviation GBM, does persist. Modern molecular diagnostic criteria still recognize this specific, highly aggressive subtype of astrocytic tumor. So in the WHO CNS fifth tumor classification, GBM is denoted as a diffuse astrocytic IDH wild-type tumor, obviously grade 4. All IDH mutant diffuse astrocytic tumors are considered as a single type, the adult diffuse astrocyte tumor, IDH mutant, and these can be graded as 1, 2, or 3. So glioblastoma in the current classification only refers to de novo lesions, which were previously considered the so-called primary glioblastoma. The concept of a secondary glioblastoma developing from malignant transformation of a previous lower-grade astrocytoma has been completely discarded. Moreover, grading is no longer entirely histological, as the presence of specific genetic mutations can confer a tumor grade of grade 4, even in the absence of the long-standing hallmarks of microvascular proliferation or necrosis. So WHO CNS5 incorporates three genetic parameters as a criteria for diagnosis of a glioblastoma, which is a diffuse astrocytic IDH wild-type tumor grade 4. And the presence of one or more of one, the TART promoter mutation, two, the EGFR gene amplification, or three, a combined gain of entire chromosome 7 or loss of entire chromosome 10, the so-called plus 7 minus 10, is sufficient to assign a WHO grade of 4. So as per the latest guidelines, glioblastoma is a diffuse astrocytic IDH wild-type tumor, and it can be diagnosed in the setting of microvascular proliferation or necrosis, or TRT promoter mutation, or EGFR gene amplification, or the gain of 7 or loss of 10 chromosomal copy changes. For IDH wild-type diffuse astrocytomas occurring in younger age groups, there's now consideration for the new classification of diffuse pediatric type high and low grade gliomas. So the high grade cohort now recognizes four types: the diffuse midline glioma, the H3K27 altered, diffuse hemispheric glioma, the H3G34 mutant, the diffuse pediatric type high-grade glioma, the H3 wild type, and IDH wild type, which would technically correspond to the pediatric version of what is now defined as a glioblastoma, and four, the infant type hemispheric glioma. So the term glioblastoma strictly is not applicable in the setting of a pediatric type diffuse astrocytic neoplasm, but there's some instances when this can occur, such as in the epithelioid glioblastoma. So histopathologically, glioblastomas are typically infiltrating highly cellular tumors of poorly differentiated astrocytes with nuclear atypia, cellular pleomorphism with marked mitotic activity. Classically, the presence of microvascular proliferation is the histopathological hallmark of glioblastoma. Tumor necrosis with or without perinecrotic pseudopallistating cells is also a fundamental feature of GBM, and its presence is one of the strongest predictors of aggressive behavior among diffuse astrocytic tumors. As the multiforme part of the obsolete term glioblastoma multiforme implies, the histopathology of the tumor is highly variable, and this feature may make it difficult to establish a reliable diagnosis with small specimens, such as that taken by a biopsy. If we look at the H&E stain of the glioblastoma before us here, we can see NE is over the necrotic part of the tumor. VP corresponds to the vascular proliferation. And in between the two of that, you can see the multiple palisades of these poorly differentiated pleomorphic cells. Cell density tends to be highest in the ring-enhancing portions of the tumor, as viable cells may not be found in the necrotic center. And this is something to take into consideration if you are biopsying a lesion for any reason. Immunohistochemical markers classically used include the glial fibrillary acidic protein, or GFAP, and most astrocytomas will stain positive for this. Astrocytomas that may not stain positive for GFAP include some poorly differentiated gliomas, the tumors that have a paucity of fibrillary astrocytes. The S100 protein is also typically expressed in glioblastomas. Three subtypes of glioblastomas are still recognized in the latest classification: the giant cell glioblastoma, the gliosarcoma, and the epithelioid glioblastoma. Giant cell glioblastoma is a rare variant of the IDH wild type GBM, corresponding to less than about 1% of glioblastomas. Histologically, you have bizarre multinucleated giant cells and in some cases an abundant reticulin network. Tends to develop in younger patients with a mid age of 51 years compared to the classic GBM at about 62 years. As with GBM IDH wild type, these tumors arise de novo with no precursor, and mutations of TP53 and PTEN are characteristic. And if we look at the slide that we have here, the arrow points towards this giant cell with multiple nuclei, and this is the classic finding in the giant cell glioblastoma. Gliosarcoma is a rare variant also of GBM, comprising about 2 to 8% of the GBMs. The histology features this biphasic pattern consisting of areas of glial cells alternating with areas of mesenchymal cells. They may arise de novo, or it can develop with following treatment of GBM or with a recurrent GBM effectively. Gliosarcomas that are predominantly sarcomatous may enhance homogeneity and give the appearance of a meningioma. If we have a look at the slide, the black arrow points towards the mesenchymal tissue, and next to it, or if we look at the blue arrow, you can see the lighter area which corresponds to the palisades of the pleomorphic cells. And this is the biphasic pattern as characteristic of gliosarcomas. The epithelioid glioblastoma, which is the last type, is the subtype of GBM that features closely spaced epithelioid cells, as well as some rhabdoid cells, in addition to the characteristics found in GBM, such as mitoses, microvascular proliferation, and necrosis. It can affect a younger population and is one of the types that you can still see in children, with a predilection for the cerebellum and the diencephalon. Molecular genetics are notable for high incidence of the BRAF V600E mutation, which we discussed in craniopharyngioma. Now, if we look at the slide, we can see the vascular proliferation. The blue arrow looks at the epithelioid, or points at an epithelioid cell, and the black arrowhead points to a rhabdoid cell. So with the introduction of the new diagnostic criteria in the WHO CNS-5 in 2021, statistics on the incidence and prognosis of GBM have had to be altered to reflect the fact that the prior studies would have grouped disparate tumors together under the heading of glioblastoma. Glioblastoma accounts for about 14% of primary brain tumors and is the most common adult malignant primary brain tumor, comprising about 49% of them. It primarily affects older adults. The mean age of diagnosis is 62 years, with a peak incidence between 55 and 85 years of age. Now, there's a slight male preponderance of about 1.6 to 1 in the US population. The Q-tip cell of origin is postulated to be a neural precursor cell in the subventricular zone. Glioblastoma is most often centered in the subcortical white matter and the deeper gray matter of the cerebral hemispheres. The lesions exhibit a predilection for the deep white matter of the temporal lobe, parietal and frontal lobe location are marginally less common. Much less frequently, the occipital lobe is involved, and spinal cord and cerebellar involvement is very rare. Infratentorial GBMs may actually represent subarachnoid dissemination of a supratentorial GBM. And if we look at the macroscopic section, it shows a classic temporal GBM. Infiltrative spread is a defining factor of all diffuse gliomas, but in glioblastoma, it is very notorious for rapid invasion of neighboring structures. Infiltration most rarely occurs along white matter tracts, can also involve cortical and deeper gray structures. Supratentorial bilateral extension may occur as a result of growth along myelinated structures, in particular across the corpus callosum and the commissures. Subsequent growth into the contralateral hemisphere can result in bilateral symmetrical lesions, the so-called butterfly glioma that we see here. Like with other diffuse gliomas, glioblastoma can manifest gliomatosis cerebral growth pattern of extensive involvement of the CNS, with the infective area ranging from most of one cerebral hemisphere, affecting 3 lobes or more, to both cerebral hemispheres, with additional involvement of the gray matter structures, brainstem, cerebellum, and spinal cord. Despite its rapid infiltrative growth, glioblastoma does not commonly extend into the subarachnoid space or spread through the CSF, although it can occur in pediatrics. Similarly, penetration of the dura, venous sinuses, and bone is exceptional. The MRI images we see to the right actually represents a case of a 71-year-old man that presented with de novo first-time seizure. And this was this scan on admission, and 68 days later, this was a repeat MRI to show you the aggressiveness of the lesion. So on clinical presentation, gliomastomas develop with a rapid progression of signs and symptoms. Symptoms depend largely on the tumor location, primarily manifesting as focal neurologic deficits such as hemiparesis or aphasia due to mass effect of the tumor itself or associated edema. Patients commonly have raised intracranial pressure leading to headache, nausea, vomiting, blurred double vision, and drowsiness, with symptomatology more prominent in the morning. There may be associated extraocular palsies, objective papilledema, pupillary abnormalities, or decreased level of consciousness. A relentless progressive headache is one of the hallmark symptoms of the tumor. After about a third of patients with GBM have seizures, and quite frequently this is the first symptom. Neurologic deficits are common and vary according to the location and extent of tumor infiltration. These deficits may be focal or global, including altered neurocognition and changes in personality. Now, in terms of imaging, CT is universally used as a first-line imaging to exclude a hemorrhage or a larger infarction, or if we're assessing anybody for neurologic deficit. MRI is obviously the preferred modality for evaluation of all intrinsic tumors. Standard T1 and T2 weighted MRI studies with or without contrast agents will reveal brain tumors with a high sensitivity with regard to size and localization. MRI will readily demonstrate mass effect edema, hemorrhage, necrosis, and signs of increased intracranial pressure. High-grade gliomas normally appear as an irregular hypodense lesion on T1 weighted MRI, with various degrees of contrast enhancement and edema. The presence of a ring-like enhancement surrounded an irregularly shaped area of presumed necrosis is highly suggestive and pathognomic of glioblastoma. In extremely rare cases, glioblastomas may initially manifest as a non-enhancing lesion, especially in elderly patients. Moreover, lower grade gliomas occasionally can demonstrate contrast enhancement. But on the MRI scene, we can see the characteristic ring enhancing lesion as almost pathognomic for the glioblastoma with the surrounding edema and the central necrosis. Functional MRI can be used to define the locations of functionally eloquent cortex, such as the motor cortex, Broca's area, Wernicke's, and the visual cortex. And this is extremely important in terms of preoperative planning. Diffusion, excuse me, diffusion tensor imaging, or DCI, can help localize critical fiber tracts. And their mapping demonstrates the displacement by the mass and is used also in preoperative planning to facilitate preservation with tracts at surgery. In up to about 40% of patients, MRI studies performed in the first month after adjuvant radiation and chemotherapy may show increased enhancement. In 50% of the cases that show this enhancement in the first month after radiation, increased enhancement reflects a transient increase in vessel permeability from treatment, a phenomenon that improves with time and is designated pseudoprogression, and this we'll discuss a little bit later on. Differentiating pseudoprogression from true progression of cancer cells can be challenging, even with advanced imaging techniques, because although MRI is the gold standard and provides excellent structural detail, it has poor specificity in identifying viable recurrent tumors in brain treated with surgery, radiation, and chemotherapy, especially in after treatment, in the first few months after treatment. Magnetic resonance spectroscopy may be used to help differentiate tumors from stroke, trauma, radionecrosis, infection, and multiple sclerosis. Now, this is more applicable to lower grade gliomas, which don't tend to enhance as much with the GBMs, which is not usually quite necessary. So it can be pretty diagnostic from standard sequences. Fluorodeoxyglucose positron emission tomography, or FDG PET, is very effective in demonstrating hypermetabolism in high-grade tumors. And it's well established that FDG uptake has a prognostic value because higher uptake corresponds to more aggressive tumor. Amino acid and amino acid analog PET tracers constitute another class of tumor imaging agents that are particularly attractive to imaging brain tumors because of their high uptake in tumor tissue and low uptake in normal brain tissue, thus yielding another contrast between tumor and normal tissue contrast. There's also evidence of superior diagnostic accuracy of fluorodopa over FDG in evaluating recurrent low and high-grade gliomas. If we look at the picture on the right, we can see right frontal glioma on MRI, and this is a corresponding PET scan with the FDG. And we can see the white area represents the high uptake of the tumor. There's globally high uptake in the cortex, but as you can see from the red and the yellow, but the white shows an extremely high uptake that's highly suggestive of a high grade aggressive lesion. Unlike GBM, the grade 4 IDH mutant diffuse astrocytomas tend not to have the large area of central necrosis. They're often larger at the time of diagnosis and they have less perilesional edema. The other diffuse astrocytoma that will fall in this high grade category, although it was a grade 3, is the oligodendroglioma, specifically the oligodendroglioma IDH mutant 1p19q co-deleted. Characteristically, this will display calcifications in about 90% of lesions on initial CT. And on MRI, it tends to be poorly demarcated, hypointense on T1, hypointense on T2, with vivid enhancement with gadolinium. Now, in terms of management, a suspected glioma or glioblastoma should be referred to a specialist multidisciplinary team at first radiological diagnosis with further management. This team would incorporate oncologists, neuro-oncologists, the neurosurgeons, the radiologists, as well as the neuro-oncology nurses, and so forth. Generally, maximum safe cytoreductive surgery followed by external beam radiation and concurrent temozolomide has become the standard of GBM management. And this strategy is the gold standard, pretty much against which all other treatments are compared. Now, in terms of management, this strategy is actually shared for the glioblastoma, as well as the high-grade diffuse astrocytoma IDH mutants, and in some cases, the IDH mutant oligodendroglioma grade 3. Now, in terms of management also, we have to include the holistic medical management of the patient. Much of the care of the patient with malignant glioma involves general medical management of signs and symptoms. So when treating these patients, clinicians must keep in mind that the most common symptoms result from peritumoral edema, seizures, fatigue, venous thrombolism, and cognitive dysfunction. Anti-epileptic drugs that do not induce the hepatic cytochrome P450 enzyme, such as Capra, is generally preferred. And there's no evidence that prophylactic anti-epileptic drugs are beneficial in patients who have not had seizures. So the return use is actually discouraged. Peritumoral edema is frequently treated with corticosteroids, such as Dexa. Long-term use, of course, is associated with Cushing syndrome, corticosteroid myopathy, hyperglycemia, immunosuppression, and osteoporosis. Patients with malignant glioma also have increased risk of venous thrombolism in the legs and the pelvic veins. Cumulative incidence approaches 20 to 30% in high-grade gliomas. Low molecular weight heparin may be more effective and safer than warfarin in treating established venous thromboembolism. Patients with malignant gliomas often experience significant fatigue and may benefit from treatment with methylphenidate or modafinil. Donepezil and memantine may reduce the memory loss, and depression is often underdiagnosed in these patients. So antidepressants and psychiatric support should be considered. Now, specifically in terms of treating the GBM, surgical intervention is usually first line. The intention is to achieve biopsy cytoreduction, and is indicated for almost all tumors suspected of being diffuse glioma. Surgery alone is never curative for these infiltrating lesions because there's no true distinct margin between brain and tumor. Aside from biopsy, the objective of cytoreduction is a maximum safe resection with the goal of gross total resection when feasible. When maximal safe resection is anticipated to be severely limited or not possible, at minimum, a biopsy for diagnostic, prognostic, and treatment planning purposes should be done since clinical and radiographic data are not definitively diagnostic of the lesion. Relative contraindications to surgery. Careful consideration should be exercised in the decision to proceed with surgical liposuction or cytoreduction surgery in certain circumstances. Their relative is no absolute contraindication. But with a high-grade glioma, GBM, we really don't want to go in with the intention to do extensive surgery in someone who has an extensive dominant lobe high-grade glioma, very elderly patient, someone whose Canopsy score is less than 70. In general, with infiltrating tumors in urologic condition on steroids is the best expected, and surgery will rarely improve this. Multicentric gliomas, patients in very poor medical condition, or lesions with significant bilateral involvement, such as the butterfly gliomas, because they cross into both cerebral hemispheres and they tend to have a worse prognosis than unilateral disease. The Balkan surgery to reduce the oncologic burden is a bit controversial due to the risk of significant neurologic deficit with no proven survival benefit. Limited surgery can be offered for large, bulky portions of the tumors, especially for ICP control, and shunting could be offered for hydrocephalus. So in terms of surgery for GBM, the objectives are one, to obtain an adequate tissue for histological and molecular study. And this can be accomplished with stereotactic guided biopsy open or needle in those patients that don't really meet the criteria for a maximal safe resection or for cytoreductive surgery. And for cytoreduction, the aim is a maximal safe resection with a goal of gross total resection when feasible. And again, the objectives would be to reduce the tumor burden, which facilitates the adjuvant therapy, and this is the oncologic goal. To reduce the mass effect, which can threaten herniation and can compress and inhibit adjacent brain tissue that is still capable of normal functioning. To reduce intracranial pressure, it may reduce peritumoral edema and it may reduce seizure frequency. Partial resection of high-grade gliomas carries risk of postoperative hemorrhage and of progressive edema, so-called in the literature, the wounded glioma syndrome, with an inherent risk of herniation and mass effect. The benefit of subtotal resection is dubious. Retrospective evidence suggests survival benefits related to gross total resection and near total resection, but not with incomplete resection. Therefore, surgical resection should be carefully considered in circumstances where gross total removal is severely limited due to location or comorbidities, as stated previously. The term maximal safe resection is really an abstraction. In many cases, maximizing the resection increases the risk of surgery, thus decreasing safety, and maximizing safety can mean compromising the extent of resection. And it's not really possible to know the exact correct stopping point for MSR in every single case preoperatively. In terms of gross total resection, remember, diffuse astrocytomas exhibit no significant line of demarcation or distinct complete brain tumoral interface. Tumor cells can always be found beyond the enhancing margins demonstrated on the MRI. So by definition, the definition of a gross total resection for diffuse gliomas that demonstrate enhancement on pre-op imaging, and this response corresponds to high-grade gliomas, grade 3 and 4, is the complete removal of the enhancing portions of the tumor or any non-enhancing portion contained within, as verified by post-operative contrast imaging within 48 hours of surgery. In terms of goals of resection, the extent of resection is reported as a percentage of the original tumor volume that was removed and should be measured on imaging studies, since the estimates made grossly by surgeons on intraoperative findings tend to be grossly inaccurate. As a metric, extent of resection fails to communicate the residual tumor burden that requires adjuvant treatment and monitoring. So some proponents have argued that the residual tumor volume, or the RTV, may be a more critical parameter to measure. The extent of tumor removal and in an inverse relationship, the residual tumor volume on postoperative imaging have significant correlation with time to tumor progression and median survival. When feasible, gross total resection with tumor with preservation of eloquent and critical structures should always be the goal. New onset postoperative deficit in motor language is associated with a significantly reduced overall survival. Various thresholds have been quoted in the literature for the minimal extensive resection to improve outcome. Studies have demonstrated that an extensive resection of greater than or equal to 98% was associated with increased survival time. Subsequent analysis focused on the residual tumor volume and concluded that the minimum required resection to improve overall survival and progression-free survival in high-grade glioma was 70% EOR and 5 centimeters cubed of RTV. Latest study found that the minimum extent of resection significantly associated with survival and recurrence was about 98%, with a maximum residual tumor volume of 2 centimeters cubed. These are the main studies that we use with regard to or refer to in terms of the extent of resection. So if you can see the lower down here, the second last study, the study by LaCroix was the one that actually introduced the concept of an extensive resection of about 98 or better percent or better, having an increased overall survival. And this was well, so it was supported by the studies by number 3 and 4 here by Oringa et al. And Sinai et al. They agree that a extensive resection that approached a gross total resection corresponded with a better progression-free survival and overall survival. Um, the one at the top, China et al. This was the one that brought in the concept of the residual tumor volume and was the latest study. And their extensive resection that was associated with increased overall survival was only 70%, but the residual tumor volume had to be 5 centimeters cubed or less. And it was later revised by the second one, Grabowski et al., and that is the one that supported extensive resection of about 98% with maximal residual tumor volume of about 2 centimeters cubed. Now, to improve the maximal safe resection, apart from standard microsurgery, there are a bunch of neurosurgical techniques that we basically use today to maximize the extent and at the same time preserve the critical structures. And these include image guidance, such as the neuronavigation or frameless stereotactic surgery. And this is extremely useful for deep tumors or in areas that border an eloquent brain. Intraoperative MRI may also increase the extent of resection, although reviews have questioned this true benefit because of the inconsistencies in application. Intraoperative ultrasound may help identify tissue with altered echogenicity that differs from normal brain, thus enhancing tumor resection. When this is used in conjunction with neuronavigation systems, it can offer real-time intraoperative imaging and potentially overcome the inaccuracy caused by brain shift because the neuronavigation is based on a static pre-op scan. Preoperative mapping with functional MRI can localize sensitive and eloquent areas of the brain. Diffusion tensor imaging sequences can also help localize critical fiber tracts, and mapping can demonstrate their displacement and aid in preservation of the tracts. And these techniques, even more helpful when merged with the preoperative image guidance. Intraoperative cortical mapping to localize critical structures is also a technique that is used. The motor strip and primary sensory cortex can be mapped with the patient awake while under anesthesia. Mapping of the speech area requires an awake craniotomy usually. A meta-analysis of 8,091 patients showed that the use of intraoperative simulation brain mapping achieved more gross total resection with less late severe neurologic deficits and is especially recommended if eloquent areas are involved. This meta-analysis, of course, included both low-grade and high-grade gliomas. For language function, the extent of resection may safely be increased using speech mapping. This also takes us back to the concept of the awake craniotomy. Now, it usually was only initially applied to low-grade gliomas that were hard to discern on the pre-op imaging, but some proponents now recommend it to achieve a maximal safe resection even in the higher-grade gliomas in eloquent areas of the brain. And some have even been talking about doing a supramaximal resection to increase your extent of resection effectively. Multicentric gliomas, previously considered unresectable, can also be debulked with the aid of awake intraoperative mapping. Despite this advanced rule of surgery, still remains limited for widespread gliomas or very deep-seated lesions. Intraoperative dyes may help distinguish the tumor from normal brain and becoming very much used for high-grade gliomas, including the indocyanine green and the 5-ALA. 5-ALA, of course, is metabolized into fluorescent porphyrins, which accumulate in the malignant glioma cells and be illuminated under the ultraviolet illumination during surgery through the microscope. It's been proven at RCT where the use of the 5-ALA leads to a more complete resection, 65% versus 30% in cases where it was not used, and this translates into a higher 6-month progression-free survival of 41% versus 21%, but there's no proven effect on overall survival. Now, after surgery, we get to the adjuvant therapy, and the standard of care for adjuvant therapy is basically described in these two protocols. So the standard of care is cytoreductive surgery followed by the so-called SUP protocol, consisting of concomitant and adjuvant radiotherapy and chemotherapy. In a prospective randomized controlled study of initial treatment of malignant gliomas, SUP and colleagues demonstrated the benefit of systemic temozolomide in combination with surgical resection and radiation therapy. They demonstrated longer survival with a median of 14.6 months in patients with glioblastoma who underwent surgical resection along with radiotherapy and temozolomide chemotherapy versus 12.1 months for those who just had surgery and radiation alone. Chemotherapy is ideally started within 6 weeks after the histologic diagnosis. And the alkylating agent, TMZ, is the drug of choice and is more effective in tumors that are deficient in the DNA repair enzyme MGMT, which we'll discuss in a little. Now, according to the protocol, the chemoradiation or concomitant phase is usually 6 weeks, commencing 2 to 4 weeks post surgery after the wound is healed, with concomitant administration of external beam radiation and oral TMZ. And subsequent to this, you have the maintenance phase. Duration initially is about 6 months. Based on the patient's specific molecular profile, it could be longer. And basically, they given oral temozolomide, and we'll discuss the dosing and the time frame. So in terms of radiation, according to SU protocol, radiation in the SU protocol consists of fractionated focal radiation at a dose of 2 grays per fraction, once daily, 5 days per week, over a period of 6 weeks, for a total dose of 60 grays, with a 2 to 3 centimeter margin of clinical target volume. Now, as a modern standard, they usually use 1.5 centimeters or 15 millimeters margin now. This is compared to the previous conventional radiation regime for malignant gliomas of about 50 to 60 gray. Previous to this, they usually would give 50 gray to the margin, 2 to 3 centimeter greater than the enhanced volume on the MRI, with a boost to the enhancing volume to get the total dose to 60 gray. Now, in terms of the radiotherapy strategy, subjects under the age of 70 in good general health with a Karnofsky performance status of 70 or greater, they get a standard regime. Subjects over the age of 70 in good health with performance status of 70 or greater uh, may receive a regimen of radiotherapy consisting of 40 gray delivered in about 15 fractions with concomitant and up to 12 cycles of adjuvant temozolomide after. So it's about 12 months temozolomide after. Subjects over the age of 70 and or under the age of 70 in poor health with a KPS of less than 50% are best served with palliative strategies and sometimes temozolomide only. Intensity modulated radiotherapy delivered by Linac is currently the recommended radiation technique for the fractionated delivering glioblastoma treatment. In terms of stereotactic radiotherapy, it's not recommended as a first-line therapy for high-grade gliomas, and it's not an option outside of therapeutic trial, since no randomized or prospective study has demonstrated benefit in terms of overall survival. For recurrent glioblastomas, stereotactic re-irradiation can be considered after individual discussion by the multidisciplinary team. Proton beam radiotherapy is not recommended for glioblastoma outside of a clinical trial. So, on the chemotherapy arm of this protocol, it basically employs temozolomide, the oral alkylated agent. This is a prodrug which undergoes a rapid non-enzymatic conversion at physiologic pH to the active metabolite monomethyl triazenoimidazole carboxamide, but let's call it MTIC. The cytotoxic effect of MTIC is associated with alkylation primarily and methylation of DNA at various sites, including the O6 and N7 positions on guanine. So in terms of the temozolomide dosing, in the initial chemoradiation phase, initial treatment, you give 75 milligrams per meter square body surface area per day, 7 days a week till the end of the radiation. And then the maintenance phase, which commences about 4 weeks later, you start 6 cycles of the chemotherapy with each cycle, and you give the temozolomide on 5 days, and this is repeated every 28 days. And the first cycle dosing is 150 milligrams per meter square per day. And with each subsequent cycle, it's about 200 milligrams per meter square body surface area per day. And this obviously initially described as 6 cycles. Some people, as we will discuss later, will tend to can take it further up to about 12 months, and some practitioners will give it until there is recurrence of disease. In terms of the side effects, TMZ causes myelosuppression, should not be given unless the neutrophil count is greater than 1.5 and the platelet count is greater than 100. For all patients with newly diagnosed high-grade gliomas, plan for concomitant TMZ and radiation. Prophylaxis against pneumocystic gyro-BCU pneumonia is recommended for the initial 6-week regime. And adjuvant monotherapy TMZ is also associated with malignant hypermutation in low-grade gliomas on multivariate analysis. And this was discovered when they tried to give TMZ as an alternative PCV for low-grade gliomas. In terms of MGMT promoter hypermethylation that we're talking about, the alkylating chemotherapy agents such as nitrosourea and the TMZ damage DNA by attaching the alkyl group, which is a methyl group, to the guanine base, forming O6 methylguanine, resulting in cell death. Now, MGMT, which is O6-methylguanine DNA methyltransferase, is a DNA repair enzyme that specifically removes the cytotoxic alkyl group and restores guanine residues to the native state. Hypermethylation of the MGMT promoter gene, something that's called epigenetic transcriptional silencing, it occurs on chromosome 10q26, and it stops production of the enzyme, reducing or removing the protective effect. Compared to normal cells, 70% of grade 4 IDH mutant diffuse astrocytomas inherently have reduced MGMT activity. This is in contrast to 36% of GBM IDH wild type activity. So the MGMT activity is actually an independent prognosticator of response to chemotherapy with the alkylating agents. Testing for the promoter is done by PCR. This usually takes about 1 to 2 weeks for a result, and it costs about $1,000 US. Measuring MGMT is faster, but this process does not always produce reliable results and requires frozen tumor specimens, which might not be available. Although methylation of 10% of the promoter gene might be reported as methylated or hypermethylated, they use the terms, they interchange the terms. It is only when the methylation is greater than 30% that the median the overall survival with TMZ increases significantly to about 25 months compared to 15 months. Analysis of recurrent astrocytomas shows some tumors with methylated MGMT promoter genes may convert to unmethylated following treatment. This is as a result of developing resistance to the TMC. So in terms of overall prognosis, glioblastoma prognosticating factors include age of patient, the Karnofsky performance status, the neurologic function status, the tumor location, the extent of surgical resection, which is notably the only real modifiable risk factor, and of course the MGMT promoter methylation status. Now, recursive partition analysis, RP for grade 4 diffuse glioma glioblastoma, is a statistical modeling method used to group patients in distinct homogeneous prognostic classes based on clinical, demographic, and molecular variables. It relies on specific decision trees to identify which factors will most heavily impact on overall survival. Organizations such as the ERTC have developed these nomograms that are available online to predict the prognosis and survival probability. So these are examples of two of them here. The one on the left is the nomogram for predicting survival in the normal GBM patient. And basically, you put in the treatment, the age, the extent of surgery, the mini-mental status examination, and whether the patient is on steroids, and they can calculate the probability of survival at 2 years. The nomogram on the right is the model basically for patients who already completed the initial stage of radiotherapy and TMZ, but the MGMT status is unavailable or unknown. And it includes age, the performance status, extensive surgery, and the mini-mental score. And again, will give a probability of survival at 2 years. In terms of overall prognosis, glioblastoma prognosis is extremely poor with survival limited to 3 to 4 months without treatment. Median survival is 14.6 months with the protocol compared to 12.1 months with radiotherapy alone, a median survival benefit of about 2.1 months. 5-year survival rate is 9.8% with the protocol in contrast to 1.9%. Regardless of the extent of resection, patients with MGMT promoter hypermethylation receiving the protocol have a longer median survival. Patients with MGMT promoter gene methylation, which again, 75% of the IDH grade 4 diffuse astrocytomas in mutants, and compared to only 36% of true GBM, they have a median survival time of 23.4 months compared to 12.6 months in non-methylated patients. Some practitioners, as I said before, extend the adjuvant chemotherapy after the standard 6-month regime until tumor progression or reoccurrence is observed. And in one study, this extended the median survival time from 16.5 months to 24.6 months. In terms of other adjuvant options, we have in the literature the Gladel wafer, which basically consists of 7.7 milligrams of camostine in pro-life % hydrophobic wafer is applied to the resection cavity after tumor excision. And these wafers are degraded by hydrolysis, and the drug is released over 2 to 3 weeks and is able to expose the tumor to about 113 times the concentration of the combusting compared to IV administration. So following tumor removal, you can put about 8 of these little dime-sized wafers at about 1.4 centimeters in diameter and about 1 millimeter thick into the bed of the cavity. And it's been shown that it increases survival to 18.8 months compared to 11.6 months in placebo groups for newly diagnosed malignant gliomas. There was no significant survival benefit when used for recurrent disease, and side effects include seizures, cerebral edema, healing complications, and intracranial infection. Now, the neuro-oncology surgical outcomes research laboratory at Johns Hopkins Hospital has demonstrated improved outcomes with a mean length of survival of 21 months in patients with glioblastoma when the treatment modalities of the gliadel, TMZ, and radiation therapy were combined after surgical resection of the tumor. Several reports in the literature have demonstrated similar outcomes. Although there are many approved and investigational drugs for treatment of glioma, at this point, the use of the tamoxifen loaded wafers combined with TMZ and radiation therapy appears to be the most effective local operative treatment for high-grade gliomas. Despite this, the availability, cost, exposure risk of surgery, and the complication profile has really affected its adoption as a standard of care in the majority of centers. In terms of novel therapies and trials, there are a bunch of different methods that have already been in use and are still being evaluated. And these include MRI-guided laser, tumor treating fields, anti-angiogenic therapy, immunotherapy, oncolytic virus therapy, and therapeutic vaccines. Now, in terms of the MRI-guided laser interstitial tumor treatment, this is a consideration for patient needing treatment when surgery is not a consideration or when the maximal dose of radiation has already been given, often in the times or the setting of radiation necrosis. A heat delivering probe is used to deliver the laser interstitial tumor treatment directed by MRI tumorimetry. Heating the tumor tissue causes a targeted hyperthermic change at a subcellular level, which results in coagulated necrosis. And there are two approved lit systems, NeuroBlate and Visualase. Real-time MRI thermometry monitors the ablation of the tumor simultaneously, and if the temperatures rise beyond a preset threshold, which can affect surrounding brain, treatment is immediately stopped. Digital stereotactic navigation tools are used to map ablation trajectories, and effectiveness has been shown in lesions that are resistant to other treatments or that are very deep and difficult to reach through surgery. LIT is equally helpful for radiation-related alterations such as radiation necrosis or recurrent malignancies. In addition, it can be used to treat high-grade gliomas that cannot be surgically removed. A meta-analysis showed that it can achieve an average tumor ablation volume of 82.9%, resulting in overall and progression-free survival of about 14.2 and 5.1 months, respectively. In terms of tumor treating fields, the Novo TTF-100A system was approved by the FDA and is a novel therapeutic approach. The first generation device was the Novo TTF-100A system and was later renamed Optune. It was authorized initially for recurrent GBM therapy in 2011 and then authorized for adjuvant therapy for newly diagnosed GBM in 2015. And the approach utilizes the targeted delivery of low intensity, intermediate frequency, alternating electric fields to inhibit the proliferation of GBM cells. The delivery of the TT fields to patient is facilitated using transducers that are affixed to the scalp. The process of mitosis is impeded by external factors leading to the eventual demise of the cell. Following the mapping process used in a functional MRI sequence, transducers are strategically positioned on the patient's shaved scalp, and the patients are recommended to employ the system at least 18 hours per day through each 4-week therapy cycle. A randomized controlled phase 3 trial was conducted to evaluate the efficacy of the tumor treating fields in comparison to chemotherapy in patients with recurrent GBM. No significant improvement in overall survival was noted, but the efficacy of the tumor treating fields was shown to be comparable to that of chemotherapy and progression-free survival. A study by Mukin et al. Supports the use of the tumor treating fields for GBM alongside the standard of care treatment protocol. The addition of tumor treating fields to TMZ therapy resulted in an increased overall survival by 4.9 months compared to patients receiving TMZ only. So this is 20.9 months versus 16.0 months respectively. Despite the perceived advantage of the tumor treatment phase, application is limited by the high price and availability issues. Anti-angiogenic therapy. So angiogenesis in glioblastoma results from several mechanisms and signaling pathways, which results in the production of an irregularly poorly constructed and poorly connected tumor vasculature. Targeting angiogenesis in GBM is aimed at the highly vascularized environment of the GBM and the rapidly progressive vascular development and this inherent prognosis or inherent effect on prognosis as the means of more aggressive tumor. Anti-VEGF antibodies such as bevacizumab or Avastin, Flixbicep, which is a VEGF trapping molecule, and tyrosine kinase inhibitors such as sorafenib have all been evaluated in GBM management. Specifically with regard to the Avastin, the antiogenic drugs such as it has been approved by FDA for malignant glioma treatment and is commonly really only indicated for glioblastoma recurrence. Although bevacizumab markedly improves progression-free survival and decreases the need for steroids, thereby having an effect on the quality of life improvement. The available data doesn't show any overall survival benefits. Bevacizumab plus resurgery improved overall survival, according to a retrospective study by Yamaguchi et al. In 2021. So this was cytoreductive surgery plus the Avastin. This is Avastin only showed an overall survival benefit of 16.3 months versus 10.4 months. But a subsequent retrospective study in 2017 found no difference between the bevacizumab combination and single regime groups. In addition, anti-angiogenic drugs are associated with increased risk of ischemic and hemorrhagic events, and there's a relative contraindication to further surgery after their use. In terms of immunotherapy, another treatment has revolutionized cancer immunotherapy treatment in recent years is the CAR T cell therapy. So CAR T cells are generated either via viral or non-viral vectors, which carry the gene encoding the so-called CAR or the chimeric antigen receptor, which recognizes a cancer-specific target. So tumor patients, T cells are collected and transformed with this CAR vector, which permanently integrates into the genome, resulting in the cells of the patient given the safest expression of CAR, of the CAR. And then using CD19 targeting CAR T therapies, they basically focus and attach to the cell and has been highly effective in the treatment of B-cell derived solid hematological malignancies, but have shown limited clinical success in targeting solid tumors. There are various trials ongoing for CAR T in recurrent GBM. So far, none have shown too much promise, primarily due to the lack of the CRT T cell expansion due to immunosuppression and downregulation. It is possible that multiple antigen targeting CARs and neoadjuvant therapy with immune stimulating therapy may boost the effectiveness of CAR T therapy, and there are ongoing trials to evaluate this. Oncolytic virus therapy is an immunotherapeutic approach with substantial promise in the treatment of GBM. It relies on selective infection and lysis of cancer cells by oncolytic viruses and a secondary antitumor response driven by the resultant cancer cell debris. So the oncolytic viruses can be used as a biologic vehicle for transgene payload delivery to the tumor site, which has further promising clinical implications. This immunotherapy may improve GBM treatment due to its ability to reprogram the tumor microenvironment, or TME, from immunologically cold to immunologically hot. This is characterized by infiltration of tumor by immune cells and modulation of the immunosuppressive milieu, thus making the tumor microenvironment more responsible to immunotherapeutic agents. So there are different types of oncolytic viruses that they use in clinical practice or in trials. The adenovirus, herpes simplex 1, measles virus, parvovirus, the poliovirus, and the Zika virus. And they all have shown preclinical efficacy against GBM cells. G46 delta is an oncolytic variant of herpes simplex 1 and is the only agent evaluated in a GBM phase 2 trial so far. 19 adult patients with residual or recurrent supernatural GBMs were administered G47 delta intratumorally for up to about 6 doses. The overall one-year overall survival was at 84.2%, and the median overall survival after treatment initiation was 20.2%, so 20.2 months, so showing significant promise. A live attenuated poliovirus type 1 vaccine, PSV-RIPO, has shown some promising results in a phase 1 study with 61 GB patients, with 20% of long-term survivors, and is currently being studied in combination with pembrolizumab in a phase 2 trial called Luminous 101. There are also now therapeutic vaccines that they are evaluated in GBM therapy. Three vaccination agents have reached phase 3 clinical trials in GBM so far. These are Rindopetamab, DCVax, and PPV. So the Rindopetamab is a specific peptide vaccine targeting a specific EGFR deletion, EGFRV3, which occurs in around 20 to 30% of GBMs, and this is associated with actually a very aggressive lesion and very poor long-term survival. Several phase 2 trials evaluating the rindopetamab in patients with newly diagnosed EGFR V3 expressing GBM showed a robust immune response and quite promising clinical data. The DC-Vax is a personalized peptide vaccine that uses autologous tumor lysate loaded dendritic cells. And in a phase 3 clinical trial, 381 patients with GB were randomized after surgery and chemotherapy to receive TMZ plus DC-Vax with TMZ alone, with a median overall survival of 23.1 months from surgery with an intention to treat population, in the intention to treat population, and 34.7 months with patients with mutated MGMT. Interestingly, in the study, around 80% of patients in the intention to treat population had a particularly extended overall survival of 40.5 months. And this is not explained by any of the known prognostic factors. A personalized peptide vaccine has also showed, or PPV has showed promising clinical activity in a phase 1 trial with 15 recurrent TMZ refractory GBs to randomized phase 2, 3 trial comparing PPV treatment. This is best supportive care. So we're nearing the end now. In terms of pseudoprogression, since the onset of or the treatment, no, the super protocol treating with radiotherapy and temozolomide became part of the standard of care for the treatment of the high-grade glioma, specifically GBM. There's been an increase in progressive contrast enhancing areas at MRI that mimic tumor progression, typically seen less than 3 months after treatment. This phenomenon called pseudoprogression occurs in about 20 to 60% of patients after radiation and temozolomide. Histologically, it resembles radiation necrosis and is believed to be associated with tumor kill by radiation. Increased tumor kill also occurs with chemotherapy, resulting in more pseudoprogression. So it tends to be more common with TMZ treatment for tumors with mutated MGMT promoter genes, as in the IDH mutant astrocytomas, which tend to have a larger population of the unmutilated MGMT than the glioblastomas. There's no definitive diagnostic test to distinguish between pseudoprogression from true progression or from radiation necrosis. Imaging methods that have been tried are MRI, fusion sequences, DWI with higher ADC maps, MR spectroscopy, and PET have not achieved high sensitivity or specificity. What appears to be an effective strategy is monitoring with serial MRIs and clinical exams. As a rule of thumb, MRI changes suggestive of GBM recurrence within the first 6 months after treatment with radiation and TMZ should be assumed to be pseudoprogression as long as it's within the radiation field. In terms of management, the MRI findings usually will improve without treatment, but if it's significantly symptomatic, some options to ameliorate symptoms include corticosteroids, Avastin, the laser interstitial tumor therapy, and hyperbaric oxygen. Pseudoresponse is another phenomenon. The gadolinium contrast agents used with MRI produce enhancement in areas where the blood-brain barrier is disrupted. Just as pseudoprogression may represent increased enhancement without axial tumor growth, agents stabilizing the blood-brain barrier tend to reduce enhancement, causing an underestimation of tumor load, or may mask enhancement through progression, and this is called the pseudoresponse. It can occur while under treatment with the androgenic inhibitors, such as the Avastin, and the enhancement may also be reduced by corticosteroids, but the effect is less, as that's seen with the anti-VEGF. In terms of the assessment of the response to treatment, the initial criteria used to assess response to treatment was the McDonald criteria. This was the system that was basically relied on, or initially described for contrast enhanced CT. Enhancement may have been affected by many factors such as steroids, inflammation, angiogenesis inhibitors, chemotherapy wafers, and so on, and as well as the phenomena that we previously described, such as pseudoprogression or pseudoresponse. The McDonald criteria have now been superseded by the RANO, the response assessment in neuro-oncology criteria. And it's an MRI-based criteria, but this is basically the Rano criteria. And therefore, uh, categories basically, and it's measured by the disease appearance on MRI effectively, as well as patient's clinical status and the dependence on medications such as the corticosteroid response state. And it can fall in the categories of a complete response, a partial response, stable disease, or progression. And this would obviously determine prognosis, the need for further treatment, or how they fare off of completed treatment. In terms of recurrence, as we recall, this disease is something that's life-limiting, highly aggressive, and it's never going to get a cure. So at some point, we'll come back. So the management of recurrent glioblastoma has to be highly individualized. So there's no single standard of care that exists once the disease comes back. Treatment, of course, at this time is palliative and aims to extend survival and preserve quality of life. Options generally include reoperation, re-irradiation, systemic therapies, immunotherapy, or clinical trials. Because GBM recurrence is unfortunately common, management strategies often depend on the patient's performance status, tumor location, and previous treatments. In terms of options, surgical resection or reoperation is a strategy to alleviate the neurological symptoms caused by the mass effect and reduce tumor volume and obtain fresh tissue for reassessment. Ideally, patients in good clinical condition where the tumor is located in an acceptable, non-eloquent location may benefit from it, but again, this is not very common. In terms of systemic therapies, chemotherapy, you can re-challenge with temozolomide or the use of nitrosoureas such as lomustine. Anti-angiogenic agents like Avastin can be used to reduce, swelling and symptoms. They will improve quality of life, but there's no true effect on overall survival. In terms of radiation therapy, re-irradiation may be considered if the tumor is localized and the patient has not reached the maximal radiation threshold from the initial treatment. And in this case, for recurrent disease, techniques like stereotactic radiosurgery can be used to allow for highly focused doses with minimal damage to healthy tissue. There's an ongoing study, the Brewer study of brain re-irradiation of chemotherapy, which is a phase 2 randomized trial of re-irradiation versus chemotherapy in patients with recurrent glioblastoma. And this is a multi-center, open-label randomized trial that is ongoing to evaluate the efficacy of it. In terms of trials that are available by clinical trial and emerging treatments, again, the immunotherapy and gene therapy that we previously discussed, patients can enroll in these clinical trials, as well as the tumor treating phase. A lot of it, though, once it recur, the patients are basically not in a very good condition, and the focus is on supportive and palliative care effectively. So symptom management with seizures, anti-seizure medication, and pain management, and focus on quality of life, such as integrative medicines like acupuncture, controlled exercises, and the involvement of the palliative care teams and so forth. And that brings us to the end of the presentation. Thanks.